We can start together. Yes, save users. We were looking at, we have already started on the anti-mycobacterial agents. Indeed, we have covered quite a number of items or quite a number of drugs. And I think the last ones we were looking at were the rifamycins. We have looked at quite a number. We were looking at the rifamycins. Of course, of importance to note is that we did mention that these are naturally occurring items or drugs that occur as a mixture of different compounds, of course, varying with a very small area within the structure. And we did mention that amongst the rifamycins, the naturally occurring, the one which was able to be crystallized was rifamycin B after using special condition of using the barbiturates in their processing or in their fermentation. And then, of course, we did mention that there is a very huge structure. This is the one we are calling it. These are answer derivatives. They have a huge structure, but unfortunately, only have a very small portion where we are allowed to do structural modification with retention activity. Just 1 minute. Just one. So I was just recapping on what we did last time. We were looking at the rifamycins, and we did mention they can only be structurally modified at a very, very small area. And we'll continue with the same. We did give examples of this we had looked at. Let me first reduce so that I can move faster. So we were looking at the rifamycin. I think we were able to even look at the SAR, the fact that the aliphatic chain or alicyclic intact. You cannot, what is all this? You cannot interfere with the aliphatic chain. You can't interfere with the hydroxyl groups at position 21, 23. They must remain intact. The area we were allowed to change, considering the big structure, we can say is very, very small. The area we were allowed to change is very, very small. But nevertheless, we did mention that area, that is position 3 and 4, has been effectively changed to give us rifamycins that have got very, very good activity, including rifampicin. You mentioned rifampicin, a molecule that is even currently used for TB. But we did mention, once you're giving rifampicin, you must be very, very careful. It's a cytochrome P450 enzyme inducer, and therefore it can cause a lot of drug interactions. And of course, with the emergence of new diseases, including the HIV and AIDS and so on, many opportunistic diseases, then you find that you have to be careful, because some of the drugs that will be used in some of those diseases are also metabolized by the cytochrome P450 enzymes, and therefore you can have a lot of drug interactions. And for that, we did mention that one has to be very, very careful when giving rifampicin, even to patients with HIV and AIDS, irrespective of its good activity. One has to be careful because of drug interactions. And I think that's where we went up to, and I think we say this morning. Today we should look at the physical chemical properties. Let me see where exactly we went. I think we had done all this. We were to look at the drugs themselves. I'm sorry, there's a button I touched and everything disappeared. I just wanted to make sure that could be this was our last slide. I believe we finished off with rifampicin, and I believe this was our last slide where we said there's avoidance of rifampicin in treatment of HIV-infected patients presently on the HIV therapies, because, as we have said, of the drug-drug interactions between rifampicin and those other drugs in terms of metabolic drug-drug interactions. So let us look at another example, which is rifampicin, and I hope you have the structures. I don't know whether I sent them to you. If I haven't, I will send them to you again. Rifampicin is also very structurally similar. Rifampicin very structurally similar to rifampicin. See whether we have its structure anywhere. There we are. So if you look at this, is rifampicin here, and this is rifampicin. So you can see they are very structurally similar. You can see they have that imine there, and they have in ring. You can see that. The only difference is that rifampicin has a methyl group. You can see rifampicin has a methyl group, whereas rifampicin has a cyclopentyl group. Cyclopentyl group in place of the methyl group, which is found in rifampicin. But you can see all the other groups are the same. So it was important for us to establish the structural similarity between the two. One has a cyclopentyl group, whereas the other one has a methyl group. So very, very similar. And that is why, indeed, we are also looking at them almost at the same time. So we are saying rifampicin, the drug's major advantage over rifampicin is the fact that when used in combination therapy, rifampicin can be administered twice weekly during the intense phase of therapy, followed by a once-a-week administration during the continuous phase. So its main advantage is the regimen. It has a less rigid regimen, or less rigorous regimen compared to rifampicin. Rifampicin is administered daily during the intense phase, followed by a twice-a-week dosing during the continuous phase. So that the more relaxed. This is once a day, once a week administration during the continuous. This is twice a week dosing during the continuous phase. So that is the regimen for the rifampicin is more rigorous than the one for rifampicin. You can, when you look at them, you're saying that one has a a cyclopentyl ring, and because of the cyclopentyl ring, it has higher lipid solubility, and of course it will have slightly higher potency than the other. So we expect rifapentine to be more potent than rifampicin, of course, also to have a slightly longer duration of activity because of its higher lipid solubility, requiring to have more intense metabolism as compared to rifapentine. Because relapse and the emergence of resistant strains of bacteria associated compliance, reduced dosing is expected to increase compliance. We are only saying if you have a less rigorous regimen, then you expect that there will be higher compliance. And if you have better compliance with the patients, then you'd expect that, of course, you will prevent the rapid. Remember, it is just preventing. At one time, you still get resistance. So you will prevent the rapid development of resistance. But of course, eventually you will have it. And that is of great, great, great advantage. I don't know why these people are just calling just now. I hope there is no more interruption. So we are saying the rifampicin is readily absorbed, following oral administration, and is highly bound to plasma proteins. It is related to higher plasma binding. Related to the higher plasma, rifampicin has a longer mean elimination. Of course, when you have a drug which has high plasma binding, it will have a longer duration of activity in comparison with the half-life reported for rifampicin. Greater than 70% of the drug is excreted in feces. You're saying because of its higher plasma protein binding, it will definitely have a longer duration of activity compared to rifampicin. It is generally considered to be more active than rifampicin and can be used in patients with varying degrees of hepatic dysfunction without the need of dosage adjustment. But remember, more often than not, the more effective, as like some of these drugs are, the more expensive they are. That is usually the problem. The problem of patients not affording these drugs. This drug, the drug similar to what is seen, induces also hepatic microsomal enzymes. So it also will induce cytochrome P450 enzyme has been reported to be teratogenic in rats and rabbits. That also is quite worrying, because once you find that a drug has a certain toxicity in animals, there is likelihood it could also cause the same in adults. And I believe that is why rifapentine is not as popular, though it has better advantages, longer duration of activity, better compliance, but it still has enzyme induction. But you find that rifampicin is still more popular than rifapentine. Of course, as I have also said, there could be also cost issues. The next is to look at their metabolism and in vitro reactions of rifampicin and rifapentine. As I said, these drugs have they have a lot of structural similarities, because we have said one has a methyl group, the other one has a cyclopentyl, and that is why we are looking at them together. So you can see, or we are saying, if you have rifampicin can react in acidic media. It can react in acidic media, and if it does react in acidic media, you get hydrolysis. So you find cleavage of the imine, of that double bond there, and you will get the 3,4 rifamycin SV, which is said is a starting material, is a precursor of quite a number of the rifamycin. So in acidic media, so again, therefore, one has to be careful of the storage of rifampicin. It cannot be in acidic media, has to be well stored because it will be cleaved. Of course, the female rifamycin SV has much lower antimicrobacterial activity. Also, the rifampicin can react with oxygen. So when, again, you cannot expose it to air. It has to be stored where, not to expose to air. If you do expose it to air, it is a group at that position number 1, 2, 3, and 4. Position number 1, hydroxyl group. Position number 4, hydroxyl group, will be oxidized to give us the quinone, the one for quinone. And of course, that also has much reduced activity than the original rifampicin. So we are saying storage of rifampicin is very important. It cannot be exposed to air because of oxidation to the one for quinone. It should not be in acidic media because it is going to be hydrolyzed. And again, also in the presence of esterases, it has an ester. If you look at position number 25 of your rifampicin, you will see it has an acetoxyl group at that position. Therefore, it can also undergo hydrolysis at that position to give us the diacetyl rifampicin or diacetyl rifapentin. That resultant group or resultant drug, I still think it is active. The resultant drug is still active because we did mention even deacetylation, the drug does not lose activity. So those are the main reactions. So metabolism of this drug mainly is through deacetylation of the acetyl group found at position number 25. So those are the metabolism and in vitro reactions of both of these drugs. So they cannot be exposed to air. They are not stable in acid, and therefore, again, storage, very important. And that is important for us as pharmacists because you see, we are saying this is a drug you might give to a patient quite some time to use for about, perhaps you might give them stocks for a month. You do need one to pack the drug well. So you need to avoid, and I believe that's what is done in most clinics. You should avoid packing that drug in papers or in envelopes. You should have proper containers, amber-colored containers, proper containers. Drug is not exposed to air because as we expose it to air, there will be degradation. So especially for a drug that is being given for some time, packaging is very important. Although some because we as pharmacists are not the ones who always dispense these drugs, and even sometimes when we dispense them, the areas where we work, the institutions in which we work, they do not provide us with the proper packaging material. So sometimes we have to do a lot of we have to improvise a lot. So you must be careful because you are the last one. You are the last person in the chain of health delivery. So you must be very careful to advise your patient accordingly. Use what you have the envelopes and use them and advise the patient accordingly. You can't pack the drugs, perhaps instead of putting all of them in one envelope, you can perhaps use 3 or 4 envelopes and tell them to store them properly. Use one package. Once you are done with it, then go to the other one. Whatever you can be able to do, because you can see these drugs are very important. The conditions they are treating are very critical conditions. They can cause death, and therefore, if you do not dispense the drugs well, then all the work will be in vain. You will have development of multi-drug-resistant TB, which can lead to a lot of death. So spectrum of activity, the predominant biological activity of the rifamycin is the inhibitory effect. Again, is the gram-positive bacteria and the mycobacteria. That is where our interest is. How good activity against mycobacteria. Some semi-synthetic rifamycin show also moderate activity against gram-negative bacteria used as natural and semi-synthetic antibiotics, namely rifamycin S, rifamide, and mainly rifampicin and rifapentin are now all of them are in clinical use. Rifampicin is a broad spectrum antibiotic of primary importance in the treatment of tuberculosis. So that even when you go out there, please look for those drugs. Please go, when you go out there, just try and find out what you are learning in class in terms of what we have mentioned, packaging, in terms of how the patients are advised, in terms of combination therapy. Are those things being adhered to? Of course, you will not go shouting at those people and telling them how much you know and how much they don't know. Remember, they are accommodating you in the institution and they can throw you out anytime. But you have to be, you have the etiquette. You must be well informed. You must use diplomacy. You must use a lot of wisdom and knowledge to be able to communicate what you need to communicate to those you find in those centers without hurting them, because you do know people are very, very sensitive. Mechanism of action, the Rifamycins act on the sense, but don't keep quiet when you have information and allow people to do things the wrong way. The Rifamycin act on the synthesis of all cellular RNAs. I had said earlier, they are inhibitors of DNA-dependent RNA polymerase. They are potent inhibitors of all bacterial DNA-directed RNA polymerases, most Rifamycin. So they will have an interference on the reproduction or on replication, and thus, of course, they will inhibit the microorganisms. Most Rifamycins are not effective on the mammalian RNA polymerase. They possess the necessary requisite for ideal chemotherapeutic toxicity against pathogens. They mainly go for the pathogens and not the host. Rifamycins inhibit the initiation of RNA synthesis, inactivating the, I think this we had already looked at, but I can't remember. Physical chemical properties of the rifampicin and rifapentin. Rifampicin and rifapentin are red, orange, crystalline compounds with zwitterionic properties. They are zwitterionic because they do have the phenolic groups. Phenolic groups are hydroxyl groups which are joined or which are added onto aromatic rings or phenyl rings. Those are phenolic, and they have very weak acidic properties. Then the rifampicin and rifapentin, look at them closely. They do have the piperazine ring. Piperazine ring, both piperazine nitrogens are basic in nature. So they are zwitterionic. They can carry a positive charge and they can carry a negative charge. They are also therefore amphoteric. They can act with bases and in acids. The presence of the phenolic groups results in acidic properties. The piperazine more it gives basic properties. That's why they indeed are zwitterionic. These compounds are prone to acid hydrolysis, as we have already shown, giving rise to the 3,4 levormycin SV. Rifampicin and presumably rifapentin are prone to air oxidation of the paraphenolic groups in the naphthalene ring to give the paraquinone, 1,4-quinone. We had already looked at that. So they can undergo oxidation to give those compounds, rifampicin, and their metabolites are excreted in the urine and feces, also in the urine, the feces, the saliva, the sweat, and tears. And one of the disadvantages of these drugs is that they are colored, and they can make you see your saliva is colored, the sweat is colored, tears are colored, your contact glasses are colored. So again, this is another thing that you need to advise the patients, that if they see changes even in the color of the urine, they do not panic. It is of the drug. Because of these agents have dye characteristics, one may note discoloration of the body fluids containing the drug. Notably, the tears may be discolored and permanent staining of the contact lenses may occur. So that's something else you should be able to advise the patient, that they might find coloration of the urine, coloration of their tears. They shouldn't not panic thinking that it's another disease. They should be aware it is because of these drugs that they are using, which can cause coloration of the body fluids. I'm also acting for COD. Pumpkin, so I have students also calling. I'm sorry about that. So we were looking at, sorry, where were we? Sorry. We are talking about the coloring of the body fluids, mainly because of the fact that these drugs do have dye characteristics. And I think that ends the rifamycins as drugs that are used in management, mainly in management of TB, very, very specific for management of TB. Do we have any question? So if we have no question, the next class of drugs that we look at is the aminoglycosides. What I had there is a summary for the students who are used to teach the aminoglycosides